A very good evening to one and all, to all the participants in India, and a very good morning to Dr. James Gutmann, who will be the resource person who will be presenting the webinar today. Warm greetings from Indian Endodontic Society and from Indian Board of Endodontics. This webinar, on behalf of Indian Board of Endodontics, which was established under the aegis of Indian Endodontic Society, will basically answer two questions. Question one, why to get board certified? And question two, how to get board certified? Frankly speaking, few years back or last decade, if you had asked me what is board certification, it is a concept which was alien to many of us dentists in India. In India, we basically look forward for our graduation and then post-graduation in our specialty, and we assume we are specialists. But board certification is an evolutionary process. In spite of your post-graduation, it is a process in which it instills in you a drive to learn and excel clinically. Hence, globally, board certification in many specialties of both medicine and dentistry is a recognized aspect to certify a person's clinical skills and acumen. The vision to start the Indian Board of Endodontics was by Dr. Anil Kohli, who in 2013 was the founder president of the Indian Board of Endodontics, and who, along with a few of us in Indian Endodontic Society, we started this board. Over this journey of these 7 years, we have tried to slowly evolve thanks to the meticulous mentorship by our international advisors, including Dr. James Gutmann, Dr. Meethu Kohli, Dr. Zvi Metzger, Dr. Hagai Shemesh, and Dr. Anil Kishan. And in this journey, we have slowly started doing the board in the form of two parts of a part one, wherein people write a written exam, and in a part two, wherein they appear in front of an international examiner with their case portfolios. So right now, today, Dr. James Guttmann would be enlightening us on how board certification can be done in an effective and an efficient manner is the main purpose of this webinar. I would like to first start this program by showing you a 2 minutes clip of the journey of Indian Board of Endodontics so far. That video gives you a brief overview of our journey over these last 7 to 8 years. Now I would like to request the President of the Indian Board of Endodontics, Padma Shri Padma Bhushan Dr. Anil Kohli sir, whose vision was to start this board, to please come and share his thoughts about the path ahead.
Thank you, Gopi. Professor James Gutmann, dear friends and colleagues. Greetings from Indian Board of Endodontics. For me, it is a dream come true. Gopi was talking about 2013. I will go little further back. My journey started 44 years back when I joined as a postgraduate student in this specialty. And I always had a dream. One day, I wanted to be recognized as an endodontist in my country. 1989, we started a small group like Indian Endodontic Society. Exactly after 24, 25 years, we have been able to reach and start in 2013 the Indian Board of Endodontics, and which was the first meeting held in Hyderabad. And it was not a easy journey. It was a tough, long journey, but not impossible. It says, I am possible. Till day, 35 people has been awarded the board certification who have cleared the part 2 exam. And 47 people have cleared the part 1 exam, and they are due for the part 2 exam in coming years ahead. This all hard work is because of the blessing of Professor Gutmann and the hard work done by the young colleagues of mine, the next generation, Dr. Gopi Krishna, Dr. Vivek Hegde, Dr. Sanjay Miglani, and others, Dr. Sangeeta. They're all part of it, and the future belongs to them. We have nurtured and we have started a tree, and the fruits have yet to come. We always had a dream. We always wanted to be recognized, and we wanted the international body should have a World Congress in our country. This young brigade of mine started working in 2010. There was a time when one person was going to the international meeting. I still remember with Dr. Kakkad I went. These people took the flag forward, and by 2020, we were being able, in 10 years hard work, we were being able to get IFIA in this country. Unfortunately, because of the corona, things we couldn't do, so we did the one conference last year, this year, 2020, and the final congress is going to happen, whether virtual or in person. That will be in August 2021, and I'm sure these people are going to bring one of the biggest congress ever held anywhere in the world, where we are expecting more than 3,000 people. This is all not one man's journey. It is we all together. It is not I, it is not Gopi or Anil Kohli. It is all of us who are responsible to bring, and we feel proud to be this. Now, coming to the point, as Gopi has already explained, what for you need the board certification? One, to promote the excellence in endodontics and the research. Second, board certification to the professionals to be recognized as an endodontist. That is another part, as he said, world over, specialties are recognizing their, although you are a master's degree in the subject, but still you need in US and other places to practice as an specialty, as an endodontics. So we decided to go forward with this aim. Then to promote advance in the specialty practice of endodontics. That is another part. One is to be recognized as an specialist. Second, to work as an specialist. And lastly, and not the least, to provide the excellence and the predictable results in the endodontics to the humanity and to the society. These are the aims. And here we are looking forward to the road ahead, none other than Professor Guttmann. I welcome you all, and with these words, I wish you all the best in these COVID times. And thanks, Gopi and the team. Even during these times, we have been able to manage Professor Guttmann, and we will all love to hear him in the next 1 hour. Thank you very much.
Thank you, sir. Thank you, sir, for your kind words. And right now, it is my proud privilege and pleasure to invite Professor Gutmann to give his oration. And before that, I would like to give a brief about Dr. Gutmann's achievements in the field of endodontics. Dr. Gutmann has completed his DDS, PhD, FACD, FICD, FDS, RCS, Edinburgh, and is a diplomate of the American Board of Endodontics and is also served as the past president of the American Association of Endodontics. He is currently working as professor, chair, and postgraduate program director, Department of Endodontics at the NOVA Southeastern University College of Dental Medicine, Florida. He is also the professor emeritus at the Texas A&M University College of Dentistry, Dallas, Texas. Dr. Guttmann received his DDS in the year 1970, and in his journey so far, he has co-authored more than 300 articles and has presented over 800 lectures internationally in over 52 countries. If ever there is a person whom I can call as the global storehouse of the knowledge and wisdom of endodontics, it has to be Dr. Guttmann. His significant contributions to endodontics has been recognized globally, and he's also the recipient of the 2011 IB Bender Lifetime Educator Award, as well as the 2017 Edgar D. Coolidge Award, which is the highest award given by the American Association of Endodontists. He is also recognized by the Royal College of Surgeons of Edinburgh with the honorary fellowship in dental surgery. He is also the international advisor and mentor for the Indian Board of Endodontics, as well as one of the examiners for the clinical case presentations of the second part of exam of Indian Board. The Indian Board of Endodontics is indebted to Dr. Guttmann for all his advice and his mentorship in evolving us so far. So I would love, when we had a discussion with Dr. Guttmann during the last exam, we felt a presentation by him in how to do this process and how to document your cases and why to do this journey of board certification is the purview of this webinar. With these words, I would like to invite Dr. Guttmann to make his presentation. At the end of his presentation, we would have a 15-minute question and answer session, which you could post on the Facebook page, and we would take up some of those questions at the end. Thank you, sir, for being part of this program, and I would like to invite Dr. Guttmann to make his presentation.
Thank you, Gopi. It's truly a pleasure to be here. First of all, I want to congratulate the board and all the time and effort that's gone into create this board. I think it's phenomenal. Secondly, that video you presented, it was wonderful. That's the first time I'd actually seen it. But I'm impressed. I really am. You people have really gone overboard in a very positive way, I think, to project the importance of this whole process to your constituents. And I'm sure that the impact that you are leaving will be a global impact down the line, especially with more and more people becoming board certified. Now, if we're lucky here, I'm going to be able to move my slides forward. Is it going fine? Did we go to the next slide?
Yes, Jim. Yes.
Okay, that's all I needed to know. Okay, we're going to have some fun today. Okay. I'm going to approach this from the standpoint that, first of all, I have never given anything like this formally. Have I done it informally with postgraduate students and students at different universities? Yes, I have. But this is the first time I've done anything formally. And I just had to kind of organize it within my own mind as to just exactly how I was going to do this and the message that I wanted to get across. So basically, it's coming down to preparing for the Indian Board of Endodontics, the pursuit of diplomate recognition, which is a very, very important goal to achieve on a professional basis. And I hope that the people that are on board today will really take it to heart, because it requires a lot of energy, requires a lot of commitment, but the rewards are there without a doubt. Now, some of the perspectives on the content of this presentation, I'd just like to give you. First of all, I recognize that many, but not all of the cultural differences that we may share. So some of the things I may say may or may not fit into the cultural nature of what you have in your country. I fully understand that, but I do understand a fair bit of your culture, which goes back to my first encounter in India, in Mangalore, and thanks to Dr. Anil Kohli, I made it in through the auspices of the people that didn't want to let me into India at that time. It was quite an interesting scenario. Anyway, during this process, I might make some recommendations. And what that means is a must-do directive. In other words, a recommendation is a must-do. This is something you really have to do to move forward with your process. I also might make some suggestions. These things are like nice to do if possible, not necessarily mandatory, but nice to do to enhance your presentation, to enhance who you are, what you're all about, and how you're going to deliver your portfolios and your oral examination. I may present issues from my perspective only, and they may or may not fit your way of doing things. That's perfectly fine. It's merely my personal viewpoint. It may work for some, it may not work for others. But the important thing is that it stimulates within you the thought process of wanting to move forward at a high level of achievement. Now, the only intent of this endeavor today is to provide you with a different yet challenging way to think about what you've done and what road you are about to choose in your professional career. Now, even in the United States, not everybody becomes a diplomate. A lot of people just leave their endodontic program and they want to go out and to a practice and just make money. They can't be bothered. However, there's a lot of issues that come into play here. If you see this present picture, basically what you're seeing is what Robert Frost gave us in 1915, The Road Not Taken. And that poem started out, two roads diverged in the yellow wood, and sorry I could not travel both. And this is where you are right now. You are at that position. And that position is position X. Now, on the left-hand side, some of you have had a straight line shot to position X. On the right-hand side, some of you have had a rather tortuous time to get to position X. But now you're faced. What do I do? Which road do I take? And at the end of Robert Frost's poem, and I'm going to share this with you because this is very important. I shall be telling this with a sigh, somewhere ages and ages hence, two roads diverged in a wood, and I took the one less traveled by. And that's made all the difference. You have to decide, do you want to take the one less traveled by? Are you willing to break new ground within yourself? Are you willing to open up your mind and expand your horizons to achieve something that not easy to achieve? In fact, I'm going to share with you the fact I made that choice many years ago. And my choice was faced with many obstacles. For example, I had to get through my advanced specialty dental education program. I was then labeled as being educationally qualified. I could go out and practice as an endodontist, but my level was just educationally qualified. Then I made application to the American Board of Endodontics, which then declared me as board eligible. And all that said was, you are now, we have recognized your credentials and you can move forward and proceed with the examination process, which was a long and tortuous one. I had a 200-question written examination, which thank God I passed. And ironically, I passed at a time just when immunology was becoming to the forefront in endodontics, and boy, was that tough. That was really tough because we were learning a whole new discipline incorporated into the art and science of endodontics. And that made it difficult. But then, even after passing that, I had to be in practice for 5 years as an endodontist before I could submit 25 cases with 2-year recalls. For those of you preparing your portfolios, just think about that. 25 cases with 2-year recalls, which had to include diagnostic cases, differential diagnosis, molar treatment cases, apexification, revision, which is retreatment, vital, non-vital cases, and at least 5 surgeries of various types, such as hemisections, root amputations, intentional replantations, apical procedures. Major challenge, especially to get the 2-year recall. My cases were accepted, and all that said was now I'm allowed to apply to take the oral examination. And then I had to sit for 2 hours, an oral examination in 2 separate rooms with 4 examiners grilling me, 4 new examiners in each room grilling me for that period of time. And what did I end up with? This is what I got. The recognition of being a diplomate of the American Board of Endodontics. And you can see the signatures of the people down on the bottom. People like Ivy Bender, Mel Goldman, Dick Mudnick, Dudley Glick, Joe Tensa, Jim Simon, Marshall Smolson. These are the people that grilled me. And, you know, I was in education at the time, full-time education. They knew I was in education, but they still grilled me. And they made me work for achieving this level of a goal within endodontics. But it's a level that allows you then to look within yourself and say, I have really risen above on so many different areas, clinically, thought-wise, research-wise, literature-wise, and I can really say I am a specialist. But that doesn't stop there, as we see as we go down the line. Now, what are the purposes of this presentation? First of all, I want to assist all endodontists who are aspiring to achieve the diplomate status. I think that's admirable. I applaud you. I pat you on the back. And during this process, as I am involved with giving oral exams, I will do everything possible to help move you through this process in a very positive way and use it as a teaching process. Secondly, I want to assist educators who are involved in the specialty education of the programs in their educational guidance during these programs so that your students achieve at the highest level so they can then move directly into this diplomate status because they are so well prepared. Thirdly, I want to elevate the awareness and the importance of the tasks that are involved in the preparation of your case portfolios. I had to prepare my cases, my 25 cases, and it wasn't easy. And I know what goes into that. And we've evolved from that. We've actually gone and made it more refined these days and made it even easier to attain, but you still have to pay attention to detail. And finally, I want to instill in all students who are pursuing the specialty education, the passion for achieving at the highest level of preparation as specialists to serve their patients with the best possible care, such that you can be proud of the fact that you have achieved not only as an endodontist, but you have been recognized as a diplomate in the Indian Board of Endodontics. And I think that's amazingly important. And again, my hat's off to Anil for starting this. I think that's phenomenal. I think you've really created a beacon in another part of the world over and above the United States, but you've created a true beacon for education and the quality of what we're trying to achieve. Now, a major nemesis, you wonder, what's that? Oh, everyone's going to run away. A challenge, a potential foe. What is it? Right now, for many of you, it's the portfolio. And some of you are probably looking at that as a nemesis. Some are looking as a challenge, and others are saying, I don't even want to consider it. But one thing I want you to keep in mind, and this is very important, these next few words that you're going to see on the bottom of the screen. Remember, your portfolio should demonstrate for any reviewer what differentiates you and your accomplishments from what could be provided by an average dental practitioner. What makes you not just unique, but more so distinct? And believe me, there's a different word, a different meaning or connotation between the words unique and distinct. Everybody's unique, but you want to be distinct. You want to stand out. You want to stand out in the delivery of the portfolio. You want to stand out in the demonstration of your understanding. You want to demonstrate a distinctness in your accomplishments such that when you do achieve that board certification, you are truly a distinct member of the dental profession. And I encourage you all to keep that in mind. You're going for distinctness, not just like everyone else is unique. What to include in each of your portfolios? First of all, there should be a separate sheet that details succinctly the nature of the case and the procedures performed and the case uniqueness. And I'll give you an example that'll come up. Now, the oral boards that I did earlier in March, yes, they had that to some extent, but not necessarily in a concise manner. And all I'm trying to do is to maybe get you people to kind of clean things up and make it very obvious as to what you're presenting to your examiner. Secondly, I would like to encourage you to provide a listing of all abbreviations that you may use in your case preparation. I ran into this in the oral boards in March. There were a lot of abbreviations. I didn't quite understand what they were, although I figured them out after a period of time. But I'm going to give you an example of the kinds of things that you can do to help facilitate. And I'm anyone that needs these slides or needs that information to help you in preparation of your cases, that's perfectly fine. So here's some examples of the abbreviations that are easily identifiable by all reviewers and will create a consistent entry of data. Now, these are just examples. There's so many more you could use. And you look right down the line. For example, treatment plan, electric pulp test, root canal treatment, history, mandibular, maxillary, chlorhexidine, calcium hydroxide, inferior alveolar nerve, within normal limits, no pathology noted, working length. Just an example of the kinds of abbreviations. And if you had that at the beginning of your portfolio and I could scan that, I'd say, okay, I know exactly where they're coming from. I know exactly what they're saying to me. And I can refer to that anytime as necessary. And I don't have to second guess. I don't have to question, what did they really mean? Just a thought. And this is only an example. I mean, there are many different ways to do it, but I'm just kind of giving you a heads up of the kinds of things that you could do. Secondly, this is a suggested format or a similar format for a rapid overview where you've got your case, your gender, your age, your procedure. For example, I'm doing root canal treatment on the right mandibular first molar. And why is it unique? It's got a radix entomolaris. A male, 10 years old, I'm doing apexification, left maxillary central incisor. What's unique? There's a history of trauma. There's a sinus tract. There's a periapical lesion. Okay. Male, 47 years of age, periapical surgery. What's unique? Failed root canal treatment, separated instrument, 2 roots, apical resorption. It gives me an overview of your whole portfolio just by looking right down the line. Every one of these cases, I will then be able to get an idea of your makeup, what you have effort and time you have put into putting this together, and the kinds of cases I'm going to be reviewing and what I expect then from you during your oral presentation of your cases. Now, some basics in case documentation and preparation. Again, these are flexible. I'm just kind of giving you some ideas which will really help you. Number one, clarity in all entries is essential. There should not be any guessing as to what's being said, and do not expect the reviewer to read into your mind as to what you mean to say or what you meant to say. Make sure it's very, very clear, okay? Secondly, in most cases, simple yet meaningful bulleted points work wonders. Also, these points can be used as mini platforms for the presentation of your case, which serves to show that, and this is the important part, you really know your case inside and out. I don't have to read line after line after line. You're going to tell me very succinctly about your case, which really tells me that you know it and you're very familiar. And it also, by the way, for those of you that are preparing your platform, it also gives me that mini platform to ask you about some literature, about some other things that might be going on in your case that maybe you didn't pick up, or things that maybe you had thought about. It allows me to dig a little deeper to find out who you are and what you're all about. Not to scare you, but to actually engender your level of confidence of what you're going to present. All radiographs should have a minimum, and this is important, a minimum of 3 millimeters of bone visibly, apically to the end of the root. So I can see the bone. I can see the nature of the periodontal ligament space. I can see important structures such as the mandibular canal or mental foramen, whatever the case might be. Cone cut radiographs really are not acceptable and should not be presented. quality of films are truly essential. And that's something you have to work on. And all of a sudden you might say, oh my gosh, oh, I had this case all worked out, but it's got a cone cut. Oh, I can't use it. I really shouldn't use it. Okay. Keep that in mind as you put your portfolios together. Yeah, I can see a bunch of you are going to be scurrying about now saying, oh my gosh, I've got to find a different case, whatever the situation might be. But that's what it's all about. Can you imagine me, 25 cases, 2-year follow-ups, and trying to make sure I had everything right? Talk about a challenge, major challenge. Some basics. Radiographs should have a direct view of the tooth in question and a minimum of one tooth on either side. If there's no teeth, at least the presence of the arch, the alveolar bone. I don't want to see a radiograph just cut down and only see the one tooth in question. I want to see what's on the rest of that radiograph, because you took that radiograph in that patient and you had a whole scope in whatever quadrant, whatever sextant, whatever it might be. I want to see that you evaluate, and I'll show you an example. I want to see that you've evaluated everything about that patient, not just the tooth in question per se. Good bite wing radiographs are essential for posterior quadrants. Absolutely. They are a tremendous help within the endodontic sector. So please do take them. Make sure all radiographs are in proper orientation and not reversed. I found that, I hate to say it, but I found that in some of the cases last time that I reviewed, where the recalls were just flipped. The tooth went from left to right and the recall. And that's, so you've got to pay attention to detail on these things. Initial radiographs, anywhere from 1 to 3, should be considered. Working length radiographs are expected to show the position of the file at the desired length for all roots on one or more films, such as a straight view or an angle view. Now you might say, well, I use the apex locator. That's perfectly fine. But do you imagine, or can you imagine the amount of information you can get from looking at a radiograph that has a working length, the files in place, and you could couple that with your electronic apex locator. And I'm not saying this is mandatory. I'm just saying it certainly is desirable to see that and to know that you've now taken a look at the curvatures in the roots and the position of the file and how it is relevant to root resorptions, or how it exits in a certain position on the root where the apex locator may not have shown you that. So it's very important that you have these kinds of films if possible. There's no, and you might say, what is he talking about? There's no endodontic diagnosis, but there is an endodontic treatment plan. So what do I mean by that? The diagnoses are pulpal, periapical, or periodicular, okay? We're not talking endodontic diagnosis. You're diagnosing the status of the pulp. You're diagnosing the status of the periapical tissues, or if they expand beyond that, the periodicular tissues, especially if it's encroaching upon the crestal bone. So make sure you give me a succinct designation that I know that you really have made that assessment of the bone and the pulp and the status around the end of the root, whatever the case might be. By the way, there's no vitality testing. It's sensibility testing. That was given to us by Francis Andresen. It's a good term. And the reason I say that is because I'm not concerned about vitality or non-vitality. Just as when you go to see a physician, you go to have your exam. Do you ever walk into a physician's office and say, doctor, tell me if I'm vital or non-vital? You don't do that. You want to know if you're sick or healthy. The sensibility testing is going to give us a better idea of sickness or health as opposed to vitality or non-vitality, because you know as well as I do, a vital pulp can be in a case, the state of degeneration. So I'd rather have you talk in terms of sensibility testing. And we'll talk more about that during the time of your presentations. Tooth assessments as to the sensibility testing should appear in a table or a chart format, which I'm going to show you an example. All tooth testing must include the teeth in question and controls, including a contralateral tooth and a tooth that has been root treated if available. Now, there's a paper put out by Furtag and Chilton and Furtag back in the 1970s, where they talked about the importance of using a control lateral tooth in your examination process and the teeth on either side. Identification of the tooth or teeth being conducted should follow a consistent entry pattern. Now, what do I mean by this? The first thing you look at is the jaw. The second thing you look at, or you look at left or right. Then the second thing you looked at maxillary and mandibular. The third is anterior, posterior, and then first or second. Use a consistent identification. I say that because some of the cases that I did review in the past, some started out, we're dealing with a mandibular second molar on the left-hand side. Well, wait a minute. Let's be consistent in delivery of where we're going, what the location is, so that I don't have to kind of guess or look ahead of time and read through the information. The information was all there, but it was kind of scattered as opposed to a nice logical presentation. And these are just suggestions, that's all. It's going to make it a lot easier for the examiner. It's also going to make it look like you really put the time and effort into your portfolio. Recall radiographs must be exposed using the same position and angulation as the final radiographs, if at all possible. I know sometimes it may be difficult to do that, but do the best you can. Don't submit, this is a very important issue. Don't submit recall radiographs where there's obvious dental disease that hasn't been addressed, such as caries, fractures, broken restorations, poor margins, obvious calculus, especially if these defects were present at the time of the initial root canal procedures. Now, I'm going to expand on that just a little bit. Even some of the cases I did in my portfolio years ago, the patient came back for recall and there was decay in an adjacent tooth or a breakdown. I repaired it myself just to make sure that I had everything on that radiograph demonstrated good quality dental treatment. Or I scaled and removed calculus before I took the radiograph, whatever the case might be. Make sure you are putting your best foot forward as a specialist. When you are doing a sophisticated procedure, the last thing you want to see is the result of a sophisticated procedure with beautiful healing, with teeth adjacent to it with caries or calculus. That says something about the overall care of the patient, so please pay attention to that. All documentation must be spell checked. Let me tell you, there was a lot of misspellings last time around. Pay attention to it, okay? Slangs and idioms are to be avoided. Use only professional language that is globally acceptable. Avoid colloquialisms. Refer to established glossaries. Now, I understand there's some differences in the language. I can deal with the Queen's English. That's not a problem. I've had plenty of experience with that. So go ahead, but be succinct. Use professional terminology. Avoid those colloquialisms if at all possible, or the idioms and the slangs that we oftentimes use. For example, the tooth had a blow up. Oh, come on, that's okay. The tooth blew up. It's things like that. Be professional. Remember, you're going at the highest level of achievement, and you want to be recognized at that highest level. There are accepted glossaries of endodontic terminology. Use them wisely. Be specific when you're providing an AHA classification with a rationale for your choice. Be specific in diagnostic terminology. Review of the published papers in the Journal of Endodontics, December of 2009, is highly recommended. We had a major conference of people from around the world in that conference in December of 2009. And believe me, we had some real battles that went down amongst us, trying to come up with accepted terminology. I'm not fully endorsing all the terminology that's there, because even though I led one of the groups, I had some difficulty with some of the philosophy that was there. But we came up with a consensus. We also came up with a minority consensus too, because for example, maybe the consensus was only 51, 52, 55% to use a certain term. What about the other 45% people? They had valid concerns. So, but I'm suggesting use the terminology from these papers and be prepared to quote these papers. Be prepared to quote the source if I should ask you that. Periodontal probing should be detailed along with all sensibility testings in a table format if possible. for ease of information. I'm going to show you all the examples coming up now. Okay, there's a perfect table. It's a suggested table, diagnostic documentation. I've used the universal tooth number. You can see exactly what we're looking for. You're doing a thermal test, either no response, abnormal response, lingering, or whatever, non-lingering, electric pulp tester, a percussion with the normal limits, degrees of discomfort, palpation, degrees of discomfort, probings. Notice, even though there's 4-point probings, mesial, buccal, distal, lingual, every endodontist should be doing circumferential probing at 0.5 millimeter increments. And that's where you find the draining sinus tracts. That's where you find the fractures. So if you want to put even more designations of probings, that's wonderful. As opposed to just saying probings within normal limits. Well, I'm not sure what normal limits are. Maybe for one patient, it would be a 4, 5, 4, 4. Other patients might be a 3, 2, 3, 3. Give me an idea, because for me, the most important endodontic tool that you have going is actually a periodontal probe, because there are many cases you have to differentiate between pulpal and periodontal disease. Mobility, make sure you use things like transillumination, check for fractures, and indicate. And then there's also other tests that you might have done, such as anesthetic test or test cavity, or you notice a darkening of the tooth. Give me this information. I can look at this rapidly and I can really say, okay, this individual who's presenting this case has really put together a nice portfolio, a nice assessment of this case. And this is giving me a lot of details for which I'm going to listen to their case presentation. And I'm now going to be able to ask them some very pointed questions. And I'm sure I'm going to get some great answers too. Another example of some procedural documentation, suggestions only. There's many ways to do this, but at least I can look at this and say, okay, tooth number 4-6 that was treated. They found 4 canals. That's wonderful. And they got good sound reference points, little difference in the measurements. This is the size of instrument that they use. And I might say, talk to me about a Vortex Blue. What do you know about that instrument? What's unique about that relative to other instruments? Do you use other instruments? So as I said, all this information serves as a mini platform for me to jump off on when it comes time to doing the oral exam. If you did a custom fit, explain to me what you did on a custom fit with your gutta perching. Tell me about the technique. Do you have a reference? What sealer do you use? Why do you use that sealer? What's in that sealer? Or I might say, you did warm vertical compaction. Take 30 seconds and tell me about your technique. How exactly do you do that? Okay. This then in your portfolio is going to give me the meat for me to work with you to be able to assess your level of achievement. Now, here's some examples of photographic documentation. Okay. Now, we had a lot of photographs in the last one, but some of the photographs were very hard to read. For example, I'm going to show you this picture. Now, what's wrong with this picture? Nothing really, other than the fact it sure would have been nice had it been squared up with the occlusal surface of the teeth, and maybe a little closer. And all this picture is showing me is a surgical procedure. Yeah, it's showing me the nature of the incision. It's showing me you've got good incisions because you've got papilla that's intact. But if I were to play around with this, I could probably come up with something like this, which would be even better, which would really give me the details of what I'm looking at. So it's take photographs. I'm encouraging you, good photograph, square them up, give me details, show me that you really have a handle on what you're doing and that this is part of your overall portfolio. Let's take this tooth, for example. This was actually one of my cases, not one of my board cases, but a treatment case. This was an 84-year-old patient that came to me, very, very nice lady. And she said, my doctor wants to take this tooth out. She points to her first molar. She wants to take this tooth out, or he wants to take this tooth out and put an implant in. And I'm 84 years old. Why do I need to even have treatment? I don't have any discomfort. I don't have any problems. Now, this is what I expect to see when you are presenting radiographs. First of all, notice it's squared up on the occlusal surface. Secondly, it gives me the teeth in question, at least a tooth on either side, and it gives me the bone around the end of the root. Let's do an assessment. Number 17, I'm assessing. This is what I expect to see from you, a large restoration. It's either a crown or it's amalgam, possible mesial caries on that tooth. That tells me you have made that assessment of that particular tooth. There's horizontal bone loss, diminished pulp chamber with calcifications, and the canals are slightly visible. Okay, wonderful. Let's take a look at tooth number 16, 1-6, large amalgam restoration, pulp chamber reduced with calcification, canals are slightly visible, a large periradicular. Now, you notice I use the term periradicular. Why? Because the lesion comes up along halfway up the root. It's around the root. It's not just sitting apically. So it's not just an apical or periapical lesion. There's a radiolucency around the mesial buccal and palatal roots. And there's possibly 4 roots, because if you look very carefully, you might even see, I don't know if you can see my mouse here, but if you can see very carefully, there's possible 1 root here, another one here. It's telling me that you are made a radiographic assessment, and there's possible caries or resorption that's present on this tooth. Distal cervical margin. Number 1-5, looks like it's an infraclusion. There's also calculus that's present. Now, if I bring this patient back, I don't want to see calculus on that tooth. I make sure that thing is cleaned up before you take a radiograph. Reduced pulpal space with calcification, no caries noted, minimal apical bone seen, so I can't make an assessment of the apical bone in that area. Okay, now what you just saw is the kind of assessment that would be great to see on your initial radiograph, maybe with even a couple angle films if necessary to show different roots. That's perfectly fine. Not just the single tooth that the patient was referred for, but an assessment of this area that is represented by the radiograph. Okay, here's the follow-up radiograph. By the way, I was able to find all 4 canals and treat it, as you can see. This is completion of the case. Now, I'm going to make an assessment. Did I extrude some material? Yes. Do I like to do that? No. Do I have some voids? Yes. Whatever the case might be. Let's do a recall now. Now, this is the kind of recall I'd like to see. You can be able to tell me that the bone is healed. There actually is a condensing or a bringing together of the sealer, which would tell me that the bone has come down closely around the palatal root. I can see the bone on the premolar. There's no calculus there, but that may not be the best film. You know why? Because I've got caries in the adjacent tooth. And if I were to present this as a board case, I might have some problems with it personally, because there's caries present on the mesial marginal of that crown, and that should have been taken care of if you're presenting this as a board case. Now, I realize that sometimes that may be difficult. If you can present a case with great follow-up and there's some minimal concern, okay, I can buy that, I can accept that. But again, we want to make sure we have the best possible treatment going. Now forget the numbers. This is just a write-up from one of my present postgraduate students, just to show you the details that they went into. And this is perfectly fine. You can do this also. You see a periapical film, you see a bite wing film. He talks about tooth 32. That's actually tooth number 4-8. Long span bridge, radiopaque crown material consistent with metal. Notice how he details receded pulp chamber, periapical radiolucency around the roots, radiopaque obturation material consistent in the premolar. And that premolar, that's not a premolar, it's actually a resected molar. So you can see some of the detail, and there's nothing wrong with presenting this kind of detail. There's nothing wrong with presenting it in bulleted form. As long as I know you've made an assessment of this environment, and I know that you've got a handle on this and you know what you're going to do and why you're going to do it. Let's take a look at another case. Another assessment. Again, keep in mind, these are our teeth number 4, 4 and 4-5. You can see the inferior root canal procedures. You can see the persistent lesions that are present. You can see a bite wing radiograph. I can see what's on top. And the student has gone through and detailed everything about all the teeth that are on these radiographs. So I know that they have a handle of what this patient's needs might be. Now, what I'm also going to show you is we've opted to, in this particular case, to go even one step farther because we've opted to use one of the newer surgical procedures. And it's not really new. It's actually been around for a long, long time, but it's only come back to the forefront. And that is what we call, well, first of all, you see that he has used the combination of the cone beam CT, which is very helpful. And when you can do that, and if you notice, he's planning a surgical procedure. He's planning the procedure and giving me the details of the distance that he's going to have to go to be able to get to these roots. And based upon that information, a choice was made. Should we just go and cut through the thick cortical bone and try to get to that depth of that root, especially on the lower left-hand side, that far lingual root on that premolar? Or should we use a technique, which is, like I say, it's not a new technique. In fact, it was really brought about back in the 1930s by Cernier, but it was brought back to life in the 1980s by Fuad Khoury in Germany. And he did multiple studies with Hemphill and Khoury on what we call in the German language, the Knockendeckel, or the bony lid approach. And this is what we did. He did the bony lid approach, where we were to cut the bone and create a window to be able now to remove that bone. And we did that because of the challenges that we were faced with in getting to the lingual aspect of the root. This is a treatment choice. I'm not saying you have to do this, but I'm just saying if you're going to do these surgical cases and you're going to document them, have a good choice for what your procedure is going to be. What teeth you're going to include, how you're going to go about doing it. And you'll be able to see combinations of now the access to the apical segment. Here, you can see the root faces here. You can see the bone has been replaced, and now we used a bone grafting material. And all this put together tells me, man, you got a pretty good handle on that case. You really made some wise choices in trying to manage that case. And here we are with a cone beam follow-up to show the root end fillings in every one of these roots, along with a periapical radiograph. Now, to me, this is a very well done case, nicely completed case. And you can see that bony lid on the upper right-hand side and in the cone beam was to avoid also the mental foramen, which allowed us. So I can talk to you about these things. I can talk to you about the anatomy, I can talk about the rationale for your approach. I can talk to you about what you used as a root and filling material, how you did it. You're putting your best foot forward. I'm not saying you have to do procedures like this. This was a gentleman, a young man who's graduating in about 2 months now, and he's actually done 10, 12, 15 cases already, and he's a very good surgeon. So he went ahead and did this. But what I'm saying is document well what you're doing. Okay, now we're just about at the end of the presentation. Now, I'm going to give you a quiz, and I want you to think about this. And you can bring this up if you have any questions during our Q&A period. Possibly the key to your success in the presentation of your case portfolios will be, I'm going to give you 7 choices. You pick which one is the best. And if you want to talk about it, great. If you want to know what the real answer is, I'll think about giving it to you. I'm not sure, but here it is. Will it be the variety of the cases that you presented? Well, that certainly is going to be a key. There's no question about that. You show me a good variety that shows you have the expertise across a wide range of activities. That's wonderful. Having wonderful case documentation, no question. It's a positive. Absolutely. Is that the key? Well, it could be, may not be. Maybe the two of those things coupled together. Presenting unusual, one-of-a-kind cases. Yeah, you are a specialist. You are going to be doing unique things. Giving me a few unique cases. Wow. Yeah, that could be the key to your success. There's no doubt about that, because you've demonstrated to me you're not just doing the run-of-the-mill type of cases that we talk about. Having long-term case follow-up, oh, well, that's always good, especially when you can show healing and show that your outcomes, in other words, you can show me what you claim to be doing is working beautifully by your techniques. That's wonderful. And that could very well be the key to your success. Good color photos that clearly depict your treatment procedures, without a doubt. That's an added benefit. That's like icing on the cake. When you can show that, You show me exactly what you're doing. I have a much better understanding of what it's all about. Adherence to the guidelines for case preparation. Hey, that goes without saying. Is that a key? It's a key, but not necessarily the major key. Now, these things that I'm presenting here are not just for you who are taking the boards, not for you that are presenting your portfolio. They're also for your teachers, for your educators to keep in mind, to help you focus on these kinds of things during your educational process, during your master's degree, so that you start to prepare for these concepts early, and you keep these on the foremost of your mind during every case that you do. And finally, is it providing a sound rationale for all your procedures? Well, yeah, you better know what you're doing, and you better be able to support what you're doing. So I leave you with those answers. You pick what you think is the best. If you want to talk about it, we can talk about it in our question and answer. Now, this is what you're going for. You're going for that beautiful diplomate certificate. It's beautiful. I think it's fantastic. I think it looks better than mine. In fact, I think it's really kind of neat, especially to have the names of those people on board. I mean, like, wow, that's impressive. So you have aspirations. You've got to have passions. You've got to see that fulfillment of your educational process. But to get there, you've got to make that commitment. It's absolutely essential. Now, your final goal and achievement will not only be the alpha, you know, an alpha and the omega, the beginning and the end, but it's also going to be the omega, because it will not be the final goal will not be your omega, because all that is a jump off point. Getting this certificate means you must continue to perform at those highest levels. You must continue to advance your skills and knowledge base. You cannot let it down. I hate to say this, but we have many people who are diplomates who have basically abandoned that knowledge pursuit. They don't need it anymore. Hey, I'm a diplomate now. I don't have to learn that stuff anymore. That's not right. That's not the way to go. And I leave you one more thing, wishing you blessings in your pursuits and attainments. And I thank you for this opportunity to share, hopefully, not just some thoughts, but also some passion and enthusiasm for what you're going to do. And I hopefully look forward to be able to work with some of you in the future as you pursue and present your portfolio. So thank you very much.
Thank you, Jim. Thank you very much for this insightful presentation. And can we have your video back on? I think you're, can you please check your video, please?
I'm back.
You're back, but yeah.
There we are. Yep. And I'm still alive too.
Now, thank you so very much on behalf of the Indian Board of Endodontics. You have made our life and our job much more easier. You have given a path not only for the people who are going to follow the board certification process, but also gives clarity to us of how do we standardize the portfolios as we go ahead. Myself and Jim, we were discussing over the portfolios over the last exam, and we were finding there's so much of diversity in the way people are trying to express their clinical work. And this presentation, I think we would also be recording and posting on YouTube and sharing it with all the participants who are going to come forward, so that we have a clear roadmap, as you rightly put, for them to take ahead. Really appreciate this. And we have some questions and we would like to have your thoughts on them. One of the most common questions asked is about the, I know your answer, because you said when you gave your portfolio, it was 25 cases and 2-year follow-up. Right now, the Indian Board of Endodontics is giving up the requisite is 10 cases, which we have given the 10 diverse cases with a 1-year follow-up. So in terms of COVID as a scenario now where follow-up and x-rays are becoming difficult, some of the participants are asking us, is a follow-up time mandatory? If in a 6-month follow-up, we are able to show healing, would that be suffice to add as a case in the portfolio?
Absolutely, as long as it's maybe 1 or 2 cases, but no more. And I understand the nature of that. If you can actually demonstrate the healing concept that is there, and you could point that out, look at this bone, patient's doing this now, and it got a new crown on the tooth, and everything else that goes with it, that's perfectly acceptable.
Okay. The other aspect comes to the concept of documentation. Is a microscope documentation mandatory for getting the cases done for board certification? Your take
No,
on
it's not. I'll be honest with you. It's great to know how to use the microscope. In fact, I'll give you a perfect example. I kind of shocked my second-year residents a few months ago because they were using the microscope, especially throughout every surgery for everything. And I said, every one of you must do a surgery without the use of the microscope. You have to see exactly what this is all about. And first of all, there was panic. But then all of a sudden, they started to realize, hey, I can actually create a better incision and tissue reflection without the microscope because I see the broader perspective. And now all of a sudden we saw bringing the microscope only over for management of the root apex. Didn't need it for suturing and all the other stuff where they were struggling with the incisions and the suturing before. So they've learned how to use the magnification or the microscope when appropriate. And that's the way I use it also. I pull it over, use it, push it back, and go from there. So no, it's not mandatory, but yes, when you do use it, to have a high skill level is important.
Okay, thank you. We have a question on whether we can submit our own published work. If we have published it or presented it, would that qualify for us to also resubmit the same cases in our portfolios?
I would say yes.
Okay.
If you've been able to publish it and you've got the quality that's there, I would say go ahead and do it. Put your best foot forward. I would have no trouble with that. Now, in the past, that was always a potential problem because I know when we went through the board process, we could not do that.
Yes.
We could not do that.
Mm-hmm.
But the fact that people have the initiative to publish something now and to get it out there in the open and you've got it documented well, let's go for it. Okay. But I would say if it's out there now, can you get another recall and give me a 2-year recall or a 3-year recall? That would be wonderful. That would really show me something. Okay.
So you need to show something more what you did after the publication.
That's right. Exactly.
Right. Dr. Vivek Hegde has a question, and he wants to know if we can document our own failures and then retreat them and show us a documentation. Would that be considered sensible approach towards the board certification?
Better than sensible. That is what it's all about.
Yep.
Because that expresses also a level of understanding and humility as a specialist, knowing none of us are perfect, and we recognize where we fell short, and we go back in. Now, that could very easily be what we call the isolated or restricted type of revision. Let's say you did a maxillary first molar and you missed the 4th canal. Now you recognize it and you make a nice small access opening. You pick up that 4th canal, either on the maxillary molar or the second distal canal in the mandibular molar, a nice small constrained access. You treat it and it heals. Wonderful. I think that's great. And for example, you did something non-surgically, it didn't fly, it didn't work. You've now made the decision, we have to go surgically. You do the surgery and it turns out perfectly fine. I think that's great. Okay. In fact, that might be the better source of some of your cases, to be honest with you.
Yeah, true. I think our own failures are the best teachers, if not.
Absolutely. And the ability to recognize I have failed, but not so much that I failed, like I made a decision, I had my choice, I did my treatment, it wasn't quite correct. Let's make a new decision and go forward.
Okay.
That's just a positive way to look at it. That's all.
Can a case which the treatment plan was right, the diagnosis and treatment plan is right, and the procedure was done right, but in spite of the best efforts, the case fails. The case fails after 1 or 2 years. Now, now, I am mentoring one candidate and I have this case. So it's my question to you. Ultimately, the case after 2.5 years, it's failing. But everything else, you can see the intent, the treatment plan, and the work done, documentation was right. Can this be included in the portfolio?
Well, it's interesting. Let me make a parallel to that. The parallel to that is exactly what our people who are doing implants are doing.
Okay.
The implant goes in, it's non-functional, the bone is breaking down, but guess what? It's surviving. It's still in the mouth. Okay, you understand what I'm saying?
Yep.
Here, you've got a tooth that gave the patient a 2, 3, 4 year, whatever. It still survived in the mouth. You did everything right, but it just didn't work. I would have no trouble accepting a case like that. I might ask that person some questions about it.
Okay.
Cause of failure. What other recourse do you have? What would you pinpoint as being? There's nothing wrong with that. I think that's great. That's the real world.
Okay.
In the past, you never put a failure in. You
Yep.
never put a failure. I mean, you might as well have taken a gun and shot yourself for putting a failure.
That
No.
was my recommendation to this candidate. I said, why do you want to, you have 10 cases to show, why do you want to end up showing a failure? But I had this in the back of the mind. So I will ask, so in the next exam, this candidate will present you that failure also.
Okay, I look forward to it. I really do.
The other question is literature, how much and where to cite when we are doing.
Okay.
Because one of the tips you asked me to keep in mind is to keep the case succinct,
Yeah.
make it crisp. So
Yep.
now, even from my point of view, where do we cite literature?
Okay, that goes back to the questions that I asked over the 7 answers.
Okay.
What's possibly the most important key to your success? It's number 7, having a rationale for what you do. So anything that you do, what technique, what this, that, if you can cite at least an article or to support what you're doing, or to say, I did it this way according to so-and-so. However, there are other ways according to so-and-so, period. That tells me you have somewhat of a handle on the literature that supports and gives you a rationale for everything you're doing.
Okay.
So you don't have to necessarily just know in your own mind. If I say to you, okay, why did you use this sealer? Oh, I use this sealer. It's a bioceramic sealer. And I know, according to so-and-so, that I can possibly now induce some cementum formation at the end of it. Wonderful. Fantastic. Okay. You got a rationale for why you use the bioceramic sealer. Simple. Keep it simple. But at the same time, try to always have a view from both sides of the coin, so to speak.
Yeah.
Especially if you're talking an endoperio case.
Mm-hmm.
Well, so-and-so says this, but on the other hand, so-and-so said that.
Mm-hmm.
I chose this, fine, okay.
I have another question from one of the candidates who's appearing, and the question is this: sometimes when we work, we are not working with the best of materials all the time.
Right.
So sometimes I have a case with, so in my 10 cases, I have a case with bioceramic sealer, and I have a case with ZOE, and I have a case with resin sealer. When I'm seeing this, from my point of view, I'm seeing this person is not consistent with all the materials they are employing. They don't believe in a concept.
Right.
Or do you say that it's fair enough? Because you can defend on either aspect. You can defend on biodentin, you can defend on MTA, but they are 2 different materials. So the question is, should you have consistency in the materials and obturation techniques with which a person is presenting?
Okay, I'll give you a perfect example. We know that, for example, if somebody were to use a core carrier technique,
Right.
just as an example, the use of a resin sealer like an AH+ actually provides better lubrication for the movement of the material in the canal than does a bioceramic, because the bioceramic it's affected a little bit by the heat situation. So you're coming in with hot gutta percha on the stick, so to speak, and it might slow the movement of the material down a little bit. Whereas you have a resin sealer, it's going to allow. So I say, I did a core carrier and I opted to use the resin because I know it's going to allow me to do this. Now, for example, there's some other sealers out there that actually have eucalyptol in them to soften gutta percha. And if someone were to say, well, I used a lateral compaction technique, but I used this sealer because it softened my gutta percha and allowed me to congeal the material together into a single mass, I'd say that's wonderful. That's fantastic. Not a problem. So there's nothing wrong with using different sealers. It's nice to know what's in them, but and it's nice to maybe use the same sealer for everything. But as you know, one size doesn't always fit all. And every canal is different. We know that a resin sealer may flow a little better in a severely curved canal. You have resorption at the apex, a bioceramic sealer might be better. So have a rationale for what you're doing.
The other question is on X-ray angle. We know that we understood from your presentation, you need consistency in the angulations with the way the X-rays are done. But do you mandate that we should have a number of shifts per view, per visit, or would you be okay with a single view?
I would be okay with a single view as long as it gives me or gives you or gives the candidate all the information they need to execute a proper treatment. That's the key thing. You know, if I'm missing something and all of a sudden it shows up later, I'm saying, well, it would have been nice to know that ahead of time. For example, when we do surgical procedures, trauma, resorptions, things that or retreatments, we personally like to see cone beams because it's going to help us. Okay, straightforward case, shouldn't be a problem. Okay, certainly single-rooted teeth, which we know are single-rooted, straight on, one view, great, wonderful, no problem. A mandibular molar, which, there might be a radix malaris. I better get maybe another little angled radiograph on that one just to demonstrate. So use common sense in what you need, that's all.
Okay. Continuing on the same on radio diagnosis, how much importance would you give to have CBCT documentation in these cases? If a person the person is unable to get a CBCT in some parts of India, they say that it's difficult. So, but they are done the work. How much importance would you give to that?
It's great to have. It's ideal to have, but it's still not the standard of care yet. Okay, no one has really labeled it as a standard of care. Hey, I did 25 cases without the cone beam CT for my boards. Come on, I didn't have that. So you got to keep that in perspective. So if you're really functioning at a high level and you know your anatomy and you know your instruments, and remember, all my cases were not done with rotary instruments, all done with hand instrumentation, Headstrom files, K files, and many of them, some of my first cases were done with carbon steel files, not stainless steel files. So keep that all in perspective. It's how you actually perform with what you have. And if we can't do the cone beam, you can't do it. But certainly, and those things that I cited, for, like I said, trauma, revision, retreatment, resorption, surgery, things like that. If you can do it, wonderful. And if you can't, you can't.
Perfect. The other aspect is on microscope is done. There's a question which has come, which I have to answer. What is the basic requisite for the qualification for somebody to go for Indian Board of Endodontics is a question which has come. There are basically two requisites. One is that you should have finished your post-graduation in the specialty of conservative dentistry and endodontics from a recognized Dental Council of India recognized institution in India. So you have to be completed your master's specialty, and the moment you complete, you are eligible to apply, and you need to be a member of the Indian Endodontic Society, under which the Indian Board of Endodontics is functioning. So these are the two requisites for that.
So that means that I could never become a diplomat of the Indian Board of Endodontics.
We have a surprise for you when you come to India. So I will talk about it later.
I have to get there first.
Now, August, you are in. The good news is we received from the Ministry of Health yesterday is 140 countries, which includes the United States of America. They are issuing the conference visas, would be eligible. So we know in August, you all are good to go to come to India.
We're every one of my people are vaccinated. We've all been through it.
We are also having the Indian Board of Endodontics Diplomat function as one of the functions during the IFIA Congress. And you were the examiner for the last batch and also for the next batch. So you would be there to hand over the diplomat certificates to all the people who clear this.
Now, let me ask you a real serious question. should I bring my academic garb with me?
Academic?
My academic gown, hat. Should I bring that with me for the presentation?
No, we would be.
Vivek is saying I should.
No, we make gowns of your size. No worry. So you come over here. We'll custom fit you. We'll custom.
I mean, I can bring it. It's not a problem.
That would be nice, but we would be able to do it. But we would have a function here, and since Vivek is here, Vivek, Hegde, and Dr. Sanjay, any of your thoughts to be asked with Dr. Guttmann before we close?
Yeah, I just got a question, Gopi. He is an Indian boy who's done his master's in the UK. He just texted me and asked me if he could be appearing for the same board exams. So I didn't have an answer for that. I thought I'll ask you and Professor Guttmann.
Well, if he's done his master's, that means he's done it conservative. He's got at least 1 year of endodontics. Is he a member of the board? Indian society, and that he would have to qualify under those two other areas. And as long as the program is recognized in India, then fine.
Yes, that should be the answer. I think yes.
That should be the answer. Yeah, I would think so.
I will convey the same. Thank you.
And I would encourage him. Definitely. Oh, if he wants to do it, that more power to him. I think that's great.
He's a product from the King's College.
Oh well, then okay, he's okay.
Dr. Sanjay, your thoughts, please.
Oh, it is always a pleasure listening to Professor Guttmann. And, during these testing times, you have brought happiness and motivation to us. So thank you so much. That's all I wanted to say.
My pleasure. My pleasure.
Jim, in that note, I would like to ask you one last question. And the last question is this. What do you think is that core one ingredient which you would see when you assess a candidate who comes for the board certification? You gave part of the answer, but I just want you to reiterate, what is it that you see which makes you feel that this person qualifies to be a diplomate?
I'd have to put it into two packages. One package has to be the overall presentation of what they've done, what they're putting in front of me. And number two, the passion with how they do it.
Okay. Thank you.
Okay.
Jim. Yep.
It's got to be there.
Yep.
And that, by the way, and that passion has got to be such, it continues after they become the diplomate. Okay. That's so key, because that's going to impact on the overall achievement in India for other people coming up the ranks.
I totally agree. And I think this presentation of yours would really make a huge impact and inspire many of my colleagues. Right now, we have all the colleges and all the teachers also listening to what you are doing, and we're trying to motivate all, not only the students. Like last time, we have many of the teachers coming in for board certification.
Yeah.
Because I think that's the first step to set the seed in the teachers before we can inspire the students.
Yeah, they got to start with them right when they start their program. They have to have this as a focus. In fact, they should put some of these concepts, even in those 7 that I put down, and put them on a big board and put them in the wall of their room, so they're looking at them all the time and say, "This is what I have to do. This is what I have to do."
Absolutely. In that note, thank you once again on behalf of the Indian Board of Endodontics, and I would like to invite the President of Indian Endodontic Society and the General Secretary, Dr. Vivek Hegde and Sanjay Miglani, to, on behalf of the board and the society, present to you right now online certificate of appreciation for all the efforts you have made. Can we have the certificate, please, on?
Well, that's beautiful. Thank you kindly.
Yeah, and we would obviously be presenting this to you in person when we meet, but it's been an absolute pleasure and honor to have you here, Jim. And
you'll send me a copy of that, won't you? Or just,
I would.
Thank you very much. I much appreciated.
Thank you. And on behalf of all of us here and from India, we look forward to welcome you in August to India and Chennai.
Sounds fantastic. I shall be there. Thank you so much.
And I hope all the listeners are motivated here, and we would be giving you all the details to appear for the board exams in the coming months and years, as well as help and motivate you and guide you. What we have done is people who have cleared the board exams, we have put them as mentors for people who are coming in, so that there is a process in which people who have cleared can mentor the next lot. Thank you, one and all, for being part of this program, and I would like to conclude this program by thanking you.
Gopi, I'd like to speak a little, please.
Yes.
In fact, Professor Gutmann mentioned Bangalore. Dr. Gutmann, Bangalore is my hometown. And one of my first meetings with you then, it's maybe 2 decades before. The point you mentioned is still in my mind. You were presenting with your presenter and the batteries went off. And you did mention this is a story of our lives. And that was a joke. It's still in my mind, you know. I still remember this. So I think energy levels are still the same or even better. You never fail to mesmerize us. Thank you so much. The magnetism is so much. It's very gripping. I think ever since I've listened to you for more than about 10 or 15 times in different parts of the world.
Yes.
And thank you so much for keeping us updated, supporting Indian Endodontic Society. On behalf of our community, as a president of the Indian Endodontic Society, as a director of the Indian Board of Endodontics, I'd like to thank you with heartfelt appreciation for the valuable inputs and also for spending some quality, precious time of yours. Thank you very much in a traditional Indian way. Thank you.
Namaste. Gopi, one more thing. Send to me, or have somebody send to me, all the details I need if some of my faculty and postgraduate students want to come to India for the IFIA. If you can send me all those details, I would appreciate it. Okay?
I would do that. I would.
Thank you so much. I do appreciate it. You have a good evening, and it's been wonderful. Thanks again for everything.
Thank you.
Bye-bye now.
Bye-bye. Bye-bye. Thank you.
Thank you, Dr. G.
Oh, you're welcome.